Okay, here we go. We're launching into our emergency medical response class. Reminding you, Mrs. Smith needs you to do some things for her. She needs you to find and fix stuff that harm her, work with the medics, explain stuff to her, help her get through this bad day that she's having. She's our focus. That's why we're learning all this stuff. It's not just so we can say we know more stuff. The whole goal here is to help her get through a problem day. And our plan is to get there promptly and safely, approach and enter appropriately, safely, be nice, be good, be safe, and help the medics. The tools, again, trucks, maps, radios, and processes. We'll practice all these things as we go through. We'll be in and out of the EMS pack many times. For this particular lesson, working on cardiac arrest, we're going to take the pack apart probably. We're going to work with you on this assessment and treatment plan, the tool that we're giving you to do some good, and the first step is this lesson. Then there's also the EMS notes and the handoff piece, and that can be very valuable in cardiac arrest. So here's the tool again. We ask you to write this on your arm and not wash it off, and so these are the 5 steps. Is this a code? And for this lesson, we're not even going to get past that. In future lessons, we'll talk about circulate, ventilate, oxygenate. We'll talk about a rapid exam where you find and fix things. We'll talk about how to record vital signs and record some history. But right now we're going to talk about, is this a code? So as you walk up to most of your patients on EMS calls, they're going to be talking to you or looking to you most of the time. If that's the case, it's not a code. Move on. And then we'll go into circulate, ventilate, oxygenate, find and fix, and the other steps. But in this case, what if they're not talking to you, they're not moving, you check for a radial pulse at the wrist and a carotid pulse at the neck, and you don't find a pulse, and they aren't breathing, this is a cardiac arrest. So we're going to designate on the radio that this is we're working a cardiac arrest, and we're going to start in. Now, one of the first steps is we're getting our equipment out. We're getting the AED, the defibrillator out. We're taking things out of the EMS bag. We need to run through a real quick list of 4 reasons why we should not work this code. These are patients, this list applies to patients who have no pulse, are not breathing, but there is not a reason that we should work this. They are already deceased. They are past our ability to reverse this cardiac arrest. That would be those patients that have an obviously mortal wound. Now the joke is, if you have to ask, it's not obvious, but I think the only real gray area there would be, maybe a gunshot to the head or something. We'll talk about this in class. But the obviously mortal wound in that they are, decapitation or something ridiculous there, where they are clearly not salvageable. What if they have rigor mortis and that they are stiff, and rigor mortis sets in long enough after the cardiac arrest has begun. So long enough after they've lost their pulse and their heart has stopped. Once rigor has set in, it's been way too long for us to have any ability to work this arrest and restore circulation. Then dependent lividity, lots of folks call it venous pooling. I can't really get a consensus on what we're going to call it. So we'll tell you that there's 2 things they call it, and then there's even a third thing that nobody says. It's called livor mortis, but if you say that, people look at you and laugh and point like you're some sort of geek. So dependent lividity, we'll show you some pictures in class, also known as venous pooling. What the deal is there is that once their heart has stopped pumping, the only force acting on their blood would be gravity, and so gravity will pull blood to the lowest part of their body, depending on what position they're in. And once that has occurred, that also shows us, just like with rigor, that the patient's heart has stopped long enough ago that we don't have any choice. And then a lot of folks have an out-of-hospital do not resuscitate. This is not the living will, not the DNR form from the hospital. This is a specific out-of-hospital do not resuscitate form. We'll show you those in class, talk about it a little bit. And this is becoming more and more prevalent because people are expressing their wishes that if they were to stop breathing or their heart were to stop, they do not wish to have any resuscitation. So you come in, you say, look at the patient. Is the patient talking to you, moving, breathing? If not, let's start getting our stuff out. Let's get the AED opened up, and let's get ready to start compressions. But we need to run through this list real quick. So you should know this list, and we will quiz you over and over and over and over on this. So let's say that your patient's not breathing, they're not moving, they don't have a pulse, they're in cardiac arrest. It's a full arrest. And we're going to work it because that list of 4, none of those apply. So how do we work it? Well, this is easy. You attach the AED, the defibrillator, and there's 2 steps to work an AED. So brace yourself. Here they come. They're really difficult. You turn it on, which in our case means you open the lid on the current AEDs that we have. You just open the lid, and it turns on. And then you do what it says. It tells you exactly what to do. Attach the pad. Stand clear. In the meantime, we want chest compressions to go on. So we're not going to just, a couple of us sit there and stare at this patient while we're waiting for the AED to say something to us. We're going to start chest compressions. One of us is. The other one's going to work around him or her, attach those AED pads, and when the AED says stand clear, then we're going to stop compressions and stand clear. There's 3 things about chest compressions that are really important. And if you do these correctly, they should make a pulse. So in the paramedic program we teach, there's 4 things about evaluating quality of chest compressions. One of them is it's actually making a pulse. The others are the right rate, and the correct rate is 100 to 120 times a minute. Faster than that is not good. Slower than that is not good. That's the rate, 100 to 120. We'll practice it over and over. We'll probably practice it, well, I know we'll practice it every session of your 5 EMR sessions, and we'll practice it a lot from then on. We also need you to push deep enough. So we need you to push a third to half the way down. Now, yes, we'll have to give you a test from American Heart that talks about the number of inches that is, but no one can really measure that on a scene, so we need a proportion. We need you to push a third to half the way down, a third to half of their chest depth. So right rate, right depth, and then we need you to let up full recoil. Now, you don't need to have your hands come off the chest, but you need to let up completely. So because the compression forces blood out of the heart, but the full recoil allows it to refill again. So right rate, right depth, full recoil. You'll be sick of hearing that, but you'll be doing really, really good compressions, because the deal is that the fire department handles the CPR. We own CPR. When the paramedic crew shows up, and they see us there, they should be able to say to themselves, oh good, CPR is handled. Now they can move on with the advanced stuff they're supposed to do. If we're not doing CPR right, they got to get it right before they can move on to their advanced stuff. So we own CPR, right rate, right depth, full recoil, and we are the manual CPR machines around here. We also do some airway and breathing management. We'll talk about that as we work through the course, but you know, if all you get done is the AED attached and some really good chest compressions, that's what the evidence says really, really matters. We borrowed or stole this, probably borrowed sounds better, this pit crew concept. The systems in the country, the fire and EMS systems in the country that are having the best success with cardiac arrest use this. So I wish I could say we invented it, but we didn't. We just copied it, but we've used it, and it makes a difference. The pit crew concept means that each person has a task, and they do that task, and they do it really well. And if everybody does their task, then things get better. And so if you've ever watched a pit crew at a race, one person has a specific task. Maybe they're the one that raises the car. Another one does the right front wheel, and another one does the left. And there's a guy that does the fueling. And I talk about this like I know what I'm talking about. But the pit crew concept is basically that each person has a role. So what are those assignments? We have a mask person, we have a bag person, we have a chest person, and we have the incident commander. Now, if we've got four people on our scene right away, we've got all four of those roles filled by a specific individual. If not, then we have to make some modifications. The mask person's whole job is to do a jaw thrust, hold that airway open, and seal that mask. That's all they do. It's really important. It's all they do. The bag person is for squeezing the bag to give ventilations and to count cycles so that we can keep track of where we are And so the medics know where we are. That counting cycles is really crucial to the paramedics for them to time what they're doing and when they're given medications and such. The chest compression person's probably got the most important job of the three we've talked about and of the four that's on the screen there. Chest compressions are really all that matters. And so the chest person handles compressions and the defibrillator. And then the incident commander is responsible for everything else. This will make more sense once we do it. I can swear to you that it's actually working and making a difference. And so we're going to help you learn this and where you can fit right in. But, oh, wait, we didn't tell you some stuff. Sometimes you're in by yourself. Sometimes you arrive by yourself on the fire truck with the defibrillator and the EMS pack. And so what should you do? Well, the priority is get the AED on. Get the AED on. And then do compressions when the AED tells you that it's okay to be doing compressions. Turn it on, do what it says, and what it's going to say is do CPR sometimes. And we're going to have you give some ventilations, but we're going to have you use a pocket mask for that. And we'll get way into why that is, but here's the quick and dirty secret. The bag valve mask is a two-person tool. So if you're by yourself, you can't use that tool. So pocket mask ventilation. But if you walk in on a code by yourself, get the AED on, and when it says stand clear, stand clear. When it tells you to do something, do it. We'll practice this over and over and over. Ideally, we would expect a two-person crew to be our minimum. But as you will find with things on the fire side, we need to work when we have 2 people, 3 people, 4 people. We need to work with variable crew sizes. That is one of the challenges of the volunteer fire service environment in this day and age, is that we may have only 2 people on this call initially. Initially is the key word. So if there's 2 of you, one of you is the mask person, the other one's the chest person. The mask person holds the airway open and seals the mask. The chest person squeezes on the chest and then squeezes the bag, and then squeezes on the chest and then squeezes the bag. Real simple, makes a lot of sense, and it works. A bag valve mask is better than a pocket mask, but it's a 2-person tool. If you've got 2 persons, you can use the tool. If we've got 3, then things get really a whole lot easier, and a lot of career departments respond with 3-person crews, and they just really can come in with this whole pit crew concept, and it works very nicely. One goes to the head, becomes mask. One goes to the chest on one side and starts compressions. The other one goes to the chest on the opposite side and operates the bag. And then after every 2 minutes, then we're going to switch. The chest person becomes the bag person becomes the chest person. The mask person never moves. So this works pretty well, and this is how you adapt to that 3-person crew. So overall, the first step here in the assessment plan is this a code? If it's a code, we need to work it. And so we're going to work it quickly, and we're going to use our pit crew, we're going to use the AED, we're going to use a bag valve mask, we're going to use a pocket mask if we're in there by ourselves. And so there's some stuff for us to work on. There's some new tools to learn. And so we'll do some several reps here right after this lesson on working the code.